I'm just going to get started. I am Haley Cronquist. I'm the Associate Director here at the Long-Term Care Community Coalition. LTCCC is a nonprofit, nonpartisan organization dedicated to improving care and quality of life for those who live in long-term care facilities. We do this through policy research and analysis, systems advocacy, public education, and we are also the home to 2 local long-term care ombudsman programs. So a little bit about our program today. We are very excited to welcome John Griffin and Alex Priest, the authors of Overbilling and Killing, an examination of the skilled nursing industry. And it's such an excellent title. It's very shocking and it's very true. So their new study brought light to critical issues within the skilled nursing industry, including unethical billing practices, systemic failures, and devastating consequences for residents. And today they will share their findings with us and what must be done to address some of these issues. And again, we will leave time at the end for questions. So please submit your questions in the Q&A at the bottom of your Zoom screen as we go. And I will hand it over to our presenters. Thank you both.
Great. Well, thank you so much, Haley, for having us here. It's definitely, we appreciate the mission of your organization and concern for care. We know there's so many in the industry that that care deeply about this. But one of the things we're going to find in this paper through the data is just that there's wide differences in practices across systems, and that has large spillover effects in terms of the quality and both the quality and the nature of billing across SNF systems. So this, as mentioned, this is a paper that Alex and I are working on. We've also assisted with some data and analysis by members of IntegraMed Analytics that also does research in the space. So if we think about Medicare costs, we see that they're growing much more rapidly than inflation, but yet even despite how fast they're growing, there's significant concerns whether Medicare payments are even sufficient to provide good quality care for patients. Now, we also know that within skilled nursing facilities or in healthcare in general, there's a conflict of interest. And sometimes profit maximization doesn't always work with the best quality of care. In other words, perhaps you could make more money by cutting back on the quality of care. And widespread differences in practices in the industry. And one of the things that motivates this, if you move to the next slide, Alex, is that the skilled nursing industry is designed to take care of patients, and we have widespread differences in rehab, and we also have differences in nursing care. So if we're going to look at starting all the way back to RUG 4, which was based on rehab, and then we're going to move forward to the new system, which is called the patient-driven payment model, or PDPM, that starts in 2019 to 2020. And although this system was set up to kind of solve some of the shortcomings of the previous RUG 4 system, we find that it didn't affect much change. In fact, the new system is gamed quite quickly, similar to the way that the old system was gamed. So if we move to our main findings, what we'll see is that there's widespread differences in practices across skilled nursing facilities. One could think of this in terms of, well, there's really good actors and bad actors in the space. And we're going to find that there are certain systems that were acting in an opportunistic manner in terms of they were basically engaged in excess rehab practices prior to PDPM back in the RUG 4 era. And those systems that were doing that quickly switched to being the highest revenue coders in the new system. And we're going to show through a variety of evidence that it's not just through proper coding, but it's actually from upcoding practices that they're engaged in at these new under the new PDPM system. And we're going to find about $6,000 per patient, which is a huge difference. And given that they make so much more, some of these opportunistic systems are making so much more than the other systems, you would think that they could provide much better quality care. But in fact, we're going to find much worse quality care. And the additional revenue is not used to provide better care. In fact, we're going to find much more instances of preventable health conditions such as bed sores, UTIs, rehospitalization, and even death differences being caused by these systems opportunistic practices. We're also going to confirm that with patient reviews using a huge data set of patient reviews and classifying those reviews as being used, whether they contain neglect or upcoding. And we're also going to say, well, why is that? Well, it seems like the systems that are capturing all this additional revenue, rather than providing more staffing, are actually providing significantly less staffing, fewer nurses, and in particular, much fewer registered nurses. So we also are going to look at the CMS quality ratings, and we're going to find that CMS quality ratings here are actually not capturing some of these differences, and that's because these opportunistic systems are gaming or misreporting the preventable health conditions to CMS. And in addition, they're expanding at a much more rapid rate. So at this point, I'm going to turn it over to my co-author Alex Priest and let him continue. Thanks.
Okay, great. So I will first start very briefly about the data and some of the methodology, and then I'll get into the more detailed findings. So the data set we're working with here is going to be the universe of skilled nursing stays. And so this will cover 14 million skilled nursing stays, which occurred from January 2016 to December 2022. So this is going to be every Medicare Part A patient in every facility over this time period. That data set's going to contain a variety of patient characteristics, diagnoses, and ultimately billing categories. Additionally, we'll merge this with the inpatient limited data set, which will give us a snapshot of the underlying patient condition at the qualifying inpatient hospital stay. Finally, we'll additionally make use of some facility level information, which is published by the Center for Medicare and Medicaid Services. As John had mentioned earlier, we will supplement this with a set of more than 70,000 patient reviews from caring.com. So as a brief overview, in this paper, we're going to be looking at billing practices over two main eras. So at the start of the sample from 2016 to September 2019, reimbursement for skilled nursing stays was under the Resource Utilization Group 4, or more commonly known as RUG 4. And Medicare reimbursement under this system was primarily based on the number of therapy minutes that were provided each week. And in particular, there were 5 distinct categories ranging from low to ultra high. Ultra high therapy, meaning that patients were receiving at least 720 minutes of therapy per week. Now, one of the issues with the RUG 4 reimbursement system is that it featured much higher rates of reimbursement for higher levels of therapy. And this created an incentive to increase therapy, even in instances that we think it's probably not beneficial for patients. And in fact, if you look at the aggregate across all providers, you'll find that the use of this ultra high therapy increased from less than 10% of all patient days in 2003 to more than 54% by 2019. A question we ask in this paper is this large increase in ultra-high rehab days, is this driven by certain skilled nursing facility systems providing excessive care? Now, this is a challenging question to answer, uh, in particular because we observe only the level of treatment that a patient actually received, and not what level a patient needed when they came into the facility. And so, in particular, this is going to make it challenging for us to be sure whether the higher levels of therapy that we're observing at these skilled nursing systems are actually indicative of excessive care. So, in particular, the approach that we'll take to solve this in this paper is that we'll start by utilizing variation in patient characteristics and diagnoses to construct an expected level of therapy utilization. So we might imagine that an 80-year-old patient with pneumonia might have very different needs than a, say, 67-year-old patient who has recently had a stroke. So we will use the underlying patient characteristics and diagnoses that are recorded at the hospital stay immediately prior to come up with an expected level of therapy utilization for that patient. Furthermore, we will define a measure, which we're going to call excess rehab. And this is the system-wide. So this is going to be the grouping of skilled nursing facilities, which are operated by the same owners and managers. And excess rehab is going to be the system-wide level of unexplained therapy provision. So this is going to be the use of ultra-high rehab days beyond what would be expected given the underlying patient conditions and characteristics that we observe. And it's worth pointing out that we're actually receiving very different levels of therapy provision at different skilled nursing systems. So in particular, patients that visited a facility belonging to SNF systems, which were in the highest 1/3 of excess rehab practices, we're actually receiving 71% more ultra-high rehab days than similar patients that visited other facilities. Now, we consider a wide range of observable patient characteristics and conditions, and we find that these differences cannot be explained by those observable patient characteristics. Furthermore, we will find that the differences in rehab provision that we observe across systems is really going to be concentrated in a 10-minute window around payment cutoffs. So to get the highest level of reimbursement, SNF systems have to provide at least 720 minutes of therapy per week. And what we find is that the differences in this therapy provision across different providers is largely explained by therapy that's provided within 720 to 729 minutes of therapy per week. And there's very little differences over this threshold. So I just want to show two images which we think are going to get at the kind of main argument of this paper. And the first is that if you consider possible explanatory variables for differences in ultra-high rehab provision, you might think, rightfully so, that patient characteristics and diagnoses should go a long ways in explaining how many days of intense rehab that a patient was receiving. And in fact, what this bar chart is showing is the amount of variation which is explained by these various characteristics. And interestingly, if you look at uh, all the set of all characteristics and diagnoses that we consider, you'll find that this actually explains even less than only including a control for who the individual SNF operator is. Furthermore, the second graph is showing us that the variation in use of ultra-high rehab across these different providers really can be explained largely by variation that's occurring within a 10-minute window around the payment threshold, which CMS itself has said indicates a focus on financial on financial profit maximization rather than patient optimal care. Now, we're not actually the first to recognize that there were issues with the incentives that the RUG-4 reimbursement scheme presented. So in particular, CMS itself expressed concerns about RUG-4 leading to overutilization of therapy minutes. So they presented a new reimbursement system, which was called the patient-driven payment model. This is a very different model of incentives. In particular, it incentivizes reimbursement away from therapy utilization towards individualized patient characteristics and needs. Now, the Medicare case mix and reimbursement under this new PDPM scheme is based on the underlying patient characteristics and comorbidities as determined by employees of the skilled nursing facility. In the interest of time, I'll skip over some of the finer details and just mention that we define a sum of 5 high reimbursement diagnoses as a measure which we call coding intensity. Now, it's important with this shift that PDPM was intended or expected to shift revenue away from residents which were previously receiving high levels of therapy. So away from these facilities which were previously using a lot of ultra high rehab towards patients which have more complex clinical needs. And so we would expect that those systems, those SNF systems, which were previously providing a lot of ultra high rehab, might actually have lower, lower levels of clinical needs. And in fact, what we find is exactly the opposite. So those SNF systems, which previously had very high levels of rehab therapy, subsequently bill for much higher levels of comorbidities under the new PDPM system. Now, a challenge that we face in this paper is trying to just answer the question about whether higher level of coding intensity could be explained by other explanations or whether it really indicates upcoding. Now, in particular, the main concern we have is that with PDPM, there's a large shift towards the reimbursement of certain diagnoses. And this might change or alter the type of patients that a facility is targeting or would like to admit. To get around this, we are going to be examining the prevalence of compensating patient diagnoses before and after PDPM as recorded by both the qualifying hospital stay. So this is a minimum 3-day hospital stay that occurs immediately prior to the skilled nursing visit. We'll then compare that to what is recorded by the skilled nursing facility itself. Now, it's important that the underlying ICD-10, the underlying patient diagnoses over this time is not changing. The only thing that's changing is which of these diagnoses are going to be higher compensating for the skilled nursing facility after the adoption of PDPM. And the test we're going to do is we'll compare the frequency of compensating comorbidities at those SNF systems, which we call opportunistic. As a reminder, that's those SNF systems which were previously in the top 1/3 of these excess rehab practices. And we'll compare the frequency of compensating comorbidities at those systems versus other SNF systems during the same time. And what we find is if you look at this blue line here, this will show us the relative presence of acute neurologic disorders. This is one of the comorbidities which increase the reimbursement for skilled nursing facilities after the adoption of PDPM. And what this blue line is plotting is it's plotting the difference in the presence of acute neurologic disorders at these opportunistic facilities versus others. So the interpretation here is that a difference of 0 tells you that the opportunistic facilities and other facilities were reporting the same level of acute neurologic diagnoses. Now, if we look at prior to PDPM, along these blue lines here, we see that there's really no difference in the reporting of acute neurologic disorders prior to the adoption of PDPM. Now, once PDPM is announced, this was the first vertical line, and once PDPM is enacted, we see that those facilities which had previously provided high levels of rehab are subsequently reporting much higher levels of the highly compensating acute neurologic diagnoses. Now, a concern we have is that it may be possible that these facilities were then admitting patients that were more likely to have acute neurologic conditions. As a test of this, we consider an external measure, which is going to be the diagnoses that are reporting at the hospital stay immediately prior. And we find that there's no difference in the presence of acute neurologic diagnoses as reported at the hospital stay. And this is not unique to acute neurologic diagnoses. This is also going to be found in SLP-related comorbidities or in other related comorbidities. And just in summary, we find that after the enactment of PDPM, facilities which previously had high levels of excess rehab subsequently experienced sharp increases in the prevalence of these compensating comorbidities, whether that be acute neurologic, SLP, or NTA related. Now, as we know, this reimbursement is based on conditions that are identified by the skilled nursing facility. And we use as a test the diagnoses at the hospital for a given patient immediately prior to the skilled nursing stay as an external measure of patient condition. And we find that the higher levels of comorbidities do not seem to be supported in the hospital claims. Thus, we argue that this is consistent with differences being driven largely by upcoding rather than patient selection. Now, finally, in the last part of the paper, which we think may actually be the most important findings from a societal standpoint, we ask what happens to what happens to this additional revenue that these facilities are producing. So we first observe that the cost of care on a per patient stay is far more expensive at these opportunistic facilities. That's true during Reg 4. It's also true during PDPM. And the difference is can be as large as $6,000. Now, you may recall when we introduced this presentation, we said there's actually significant disagreement among providers about whether Medicare reimbursement is truly adequate to provide the quality of care that patients need. So a natural question is to ask whether these system billing practices are related to quality of care. And this is an inherently difficult thing to measure, so we'll focus on a variety of different sources. So first, we will focus on the incidence of patient health outcomes, including the development of preventable health conditions, such as pressure ulcers or ETIs. We'll also look at rehospitalization as well as mortality within 90 days. Finally, we'll consider some independent measures of quality, which includes patient reviews. And when we investigate the mechanism, we'll find lower levels of staffing using the CMS files. So just as a motivating piece of evidence for this, if we plot the system level excess rehab, that is the excessive rehab under Reg 4, that'll be on the horizontal x-axis, versus the system level coding intensity on the vertical y-axis, we'll first find a positive correlation. That is, those skilled nursing facilities which previously had very high levels of excess rehab go on to have higher levels of coding intensity. Now, if you look at the color of these dots, this will show the proportion of patients which are either rehospitalized within 30 days or which are experiencing death within 90 days of leaving the facility. You'll notice that as we shift towards the upper right, these dots are getting darker. That means that the patients at these facilities are actually more likely to be rehospitalized or experience death within 90 days. Now, this is this is our first piece of evidence. We look at this in a more formal statistical setup. Now, importantly, in order to compute these various measures, such as pressure ulcers or UTIs, we need to merge the skilled nursing facility data with the inpatient and hospice data sets. And I'll have something to say at the very end about why this kind of step is necessary. But importantly, we will consider a patient to have a facility-acquired pressure ulcer or bed sore if that patient is admitted to the hospital within 1 day of leaving the skilled nursing facility and is recorded as having a new bed sore, that is a bed sore that's present on admission at the new hospital stay that was not documented when they were admitted to the skilled nursing facility. Now, importantly, this should be a very conservative lower bound, since it's going to assume that the only possible patients which could have developed a bed sore or UTI are those patients which are admitted within 1 day. And when we do the more formal statistical analysis, we'll find actually that yes, it doesn't matter what metric you use, patients at facilities which had higher excess rehab are more likely to experience pressure ulcers, UTIs. They're also more likely to be rehospitalized or to experience death within 90 days. Furthermore, these effects are actually quite large. So to give you some idea, if you were to shift from the first to the third tercile of excess rehab, you'll find that this is actually predicting increases in rehospitalization of 2.7 percentage points, increases in mortality of 2.4%. Regardless of the patient health outcome we use, we find that patients at these facilities are more likely to develop adverse conditions. We also consider a variety of other data sources, one of which is patient reviews. So as I had mentioned, we gather a set of 70,000 patient reviews, and we think that these reviews are likely to have considerable information about facility quality that would be difficult to externally quantify. So just to kind of give you a snippet of one part of these reviews, was this person which was talking about their dad, which is in a facility, said, I came and they had numerous bed sores, was never moved for days. We asked the nurse about it and she said, hey, I'm the only one here for over 30 patients. Now, of course, these reviews make very interesting anecdotes. To more formally investigate these, we use a support vector machine, which is a supervised machine learning algorithm, to identify reviews that could indicate abuse. Now, this starts with a manual classification of 100 reviews that are identified as abusive, 100 reviews that are not. So an abusive review would be one like this example I'm presenting here. And we find that, unfortunately, reviews indicating abuse or neglect are actually fairly pervasive. So about 15% of reviews are classified as indicating abuse. In this paper, we also ask whether SNF systems billing practices are associated with higher levels of abuse. And we find that they are. So in fact, patients that are leaving reviews at these systems, which had previously higher excess rehab, so at these systems with poor or unethical billing practices, are actually far more likely to leave a review, which our algorithm is going to classify as potentially indicating abuse. And these differences are really quite large. So patients at the worst facilities are 2.5 times more likely to leave a review, which is indicative of abuse or neglect. Finally, we turn to the nurse staffing levels. So as we all know, nurse staffing is very important for patient health outcomes. And we view this as one of the primary channels for which the adverse health outcomes are coming from. So in particular, what we look at is the number of nursing hours per resident day. And we find that regardless of the category, but particularly true for registered nursing, those facilities which are ranking high in excess rehab, so those facilities which have potentially poor billing practices, despite getting much higher levels of revenue on a per patient basis, actually seem to be underinvesting in the care that they're providing patients. So if you look at the nurse staffing hours per resident day, you'll find much lower levels. This is particularly strong among the subset of registered nurses. So in particular, you'll find that the worst facilities are hiring about 40% fewer registered nurses per resident day. And so despite getting much higher levels of revenue, they seem to be underinvesting in the provision of care. So just to summarize quality of care, we find that patients which are visiting these opportunistic facilities are more likely to develop bed sores, they're more likely to develop UTIs, and they're also more likely to be hospitalized or to die within 90 days of discharge. When we look at patient reviews, we find that patient reviews at these opportunistic facilities are 2.5 times more likely to describe abuse or neglect. Now, despite getting much higher levels of revenue, opportunistic facilities are providing consistently fewer staffing resources per patient. And an additional finding that I don't talk too much about in today's presentation is if you look at the random health inspections, you'll also find that these opportunistic facilities are experiencing much higher levels of deficiencies and much higher levels of severe deficiencies. Now, the last part of the paper is exploring from an economist standpoint why it is that these poor practices are able to persist. So, well, we know that Medicare does not directly condition payment on the quality of treatment. Facilities could still face market discipline if patients refuse to visit these poorly performing facilities. Now, a challenge for this to be an effective disciplining mechanism is that we know that patients may have difficulty accessing or understanding the quality of an underlying facility. Now, of course, you could think that this might be solved if Medicare provides this data for patients. And in fact, Medicare does provide they do provide prospective patients with facility level information and ratings via the Care Compare Care Compare website. Now, a potential issue is that one of the main determinants of facility level ratings is going to be the quality ratings. And quality ratings are measuring health outcomes that patients at these facilities report. Now, an issue is that these quality ratings are reliant on data that's self-reported by the skilled nursing facilities. And so there's some concern that facilities might choose to underreport the development of adverse health outcomes. So the idea, which I mentioned briefly earlier, is that we use the fact that with the Medicare data, we can track the entire history of a patient's health outcomes. And in particular, we use this to construct a lower bound, so a very conservative estimate of the facility acquired health outcomes. And then we're going to compare those to what the same skilled nursing facility reported to CMS, which is incorporated in the quality ratings. And we're going to classify a facility to be highly underreporting if the lower bound that we calculate is at least double that of which is reported in the quality ratings. And if we look at this, we're going to find two main things. First, if we look at the y-axis, we'll find that anywhere between 20 and 50% of facility quarters are going to be classified as severely underreporting the development of pressure ulcers. So this will be for pressure ulcers. You're going to find similar if you look at UTIs, for example. So first, underreporting preventable health outcomes unfortunately seems to be quite pervasive. So despite the fact that we constructed a very conservative lower bound, despite the fact that we're only considering a facility corridor to be highly underreported, if the lower bound we calculate is at least double what is reported to CMS, we find that somewhere around 1/3 of facility corridors are going to be classified as highly underreported. Furthermore, this pattern is very much related to the underlying billing practices by the skilled nursing facilities. So the horizontal x-axis is showing the system excess rehab. And we find that those facilities, which had previously had very high levels of rehab just above threshold cutoffs, are actually much more likely to underreport the development of pressure ulcers. They're much more likely to underreport the development of UTIs. And the overall effect of this is that CMS quality ratings themselves are often gamed. So although CMS is reporting this information to prospective patients, one of the reasons that prospective patients may have a difficult time ascertaining facility quality is that those facilities with the worst billing practices are the most likely to game or underreport um, the development of pressure ulcers and UTIs. This feeds into the quality ratings. And so as a result, these CMS quality ratings themselves are often gamed. Now, we also ask whether there seems to be any regulatory pressure, which is disciplining use action. So in particular, it could be that regulators are better able to monitor facility or system level practices. It could be that they use this information to block mergers or acquisitions. Unfortunately, this is not what we find. So those systems which are in the highest 1/3 of excess billing practices, if you look at the mergers and acquisitions activities, you find that these systems are expanding at 2.5 times the rates of the lowest third of billing practices. So unfortunately, it looks like those systems which are using questionable billing practices to extract much higher levels of revenue that are then underinvesting in patient care are using these excess funds to fuel growth and expansion, and they're growing at much higher rates, indicating that these poor practices themselves are likely to also be expanding. With that being said, I'll conclude briefly, then we're very happy to take questions. So first, despite the intentions of CMS, we find that a very large change in the payment scheme doesn't seem to deter SNF systems from engaging in excessive billing practices. Furthermore, we argue that the discrepancies in billing levels that we observe don't seem to be explained by patient heterogeneity. They don't seem to be explained by selective admission or superior diagnostics. They are consistent with upcoding practices. We use 3 distinct measures of quality of care, and these all suggest that excessive billing practices are associated with lower, not higher quality of care. Finally, underreporting of health outcomes by facilities makes it challenging for the general audience to gauge facility quality. And the end result is that facilities with the most aggressive billing practices are rewarded under the current system. And one way we observe that is they're experiencing much higher levels of growth. So with that, we'd just like to say thank you. We're very much looking forward to questions. And if they have questions that we don't get to today, here is our contact information.
Thank you so much, Alex, and thanks to John as well. We definitely have some questions in the chat, so I am going to just go through some of those. So the first question is from Sam Brooks. He said, were there defining characteristics for these excess billing facilities? For instance, were they for-profit or nonprofit, part of a chain?
Yes, they these most of our results focus on the chain level practices, And we find that the chain level practices explain behavior much better than looking at individual facilities. So things may be a little difficult to measure at an individual facility, but chains typically have similar practices across facilities. And we do look at, in the last part of the paper, we do look at for-profit, not-for-profit, private equity, non-private equity, so forth. We find that, yes, it's the case that for-profit facilities on average are a little worse, but it's not, there's wide differences across practices at for-profit facilities. So you can't just take away from this that for-profit's bad and there's nonprofit facilities that are not great either. So there's wide differences in practices.
Thanks. So the second question is also from Sam Brooks, the Consumer Voice. He says, clearly PDPM is easily gamed. What can CMS do? Providing residents and families with information is great, but shouldn't CMS be doing something to address this issue?
Look, I can't really speak to another organization. I can just speak to the fact that, yeah, we're very much trying to bring light on this space. We've been trying to do so for a while. And as part of that action, we did release a website recently, care.watch. And I put that in on the chat. I don't know if it on the Q&A, I don't know if it came up or if it was in the sidebar, but it's care.watch. And we construct our own measures based on to rate these chains and facilities, and we put it on a map. And we're not putting the website. We're not making any money off the website. We're not advertising anything on the website. We're just putting the website up there because we do think there's not enough information out there, and we think that we put various measures of ratings for these facilities so that people can have a sense for what the data says about these facilities.
Thanks. So actually, just based on something you mentioned there, I'm just going to jump to an anonymous question. What inspired you to investigate the issue of overbilling and potential harm in the skilled nursing industry?
Well, I've been doing research in forensic finance for quite some time, 14 years now. And one of the things we hope to do by doing that is to not just have research that is interesting to academics, but we really want to try to expose bad practices and bring bad things to light and have them stopped. And in particular, the medical space is one that also there's a lot of available data, but it also has similar conflicts of interest and it has similar issues. So we thought that maybe we could study some of the methods and some of the questions that we use in finance. We thought maybe we could learn about it in this space and go in. And sure enough, yeah, there's a lot of issues in the medical space, and particularly we think Alex and I are very concerned about the justice component here. And we think that in the medical space, perhaps the justice aspect is even larger than some of the finance things we've worked on. So, yeah, we're glad people are interested in this, and we appreciate all the great quality work that many people in the medical space do. And there's so many people that care. And unfortunately, there's some bad actors that are in the space, kind of corrupting things. And so we want to try to call that out and hopefully get more good actors in the space.
Yeah, thanks. I think everyone on this webinar feels the same about getting at these bad actors. So thanks for your work on this. Another question, another anonymous question. What would you like to see stakeholders such as policymakers, advocacy groups, and families of residents do with the information in your study?
Well, I would like to. I do think we need to. I do think people have strong feelings about a lot of things, but I think some of what's going on at some of these facilities is criminal, and I'd like to see. Maybe it's hard to prove, but I would like to see more serious more serious actions against some of these bad offenders, in particular the top. It goes all the way up to the top management. And so, in addition to that, I do think if we could spread more information in terms of who the bad actors are and so forth, that that could help reduce people putting their loved ones in these bad facilities. So I do, to the extent that someone is harmed and has information, it's great to call that information out.
Yeah, thanks. So we have a couple questions from Eileen Henshaw. Hi, Eileen. Glad you were able to join us today. The first one is, do we have any way to determine whether therapies billed for were ever actually provided?
Yeah, usually we don't. So the therapy could be the therapy relates to the RUG-4 era, and so the therapy could be provided. They're providing it just above the amount they need to get to the next billing. So if that suggests if you were really sitting down and trying to diagnose somebody according to their needs, you might say, well, they need 400. They need about 400 therapy minutes. But if you can reach the next threshold by giving them an extra X many number of minutes, then the therapy would come in right above the threshold. So that's typically what we're finding in the data, is that most of it's right above the threshold, suggesting they're just trying to reach the revenue threshold, not necessarily looking at what exactly the patient's therapy needs are. But then, they switched the system from RUG-4 with a therapy focus to the PDPM system, and that system rewards comorbidities. And we see that many of these patients are getting these strange comorbidities that were never diagnosed in the preceding hospital stay, right prior to their visit. So that's pretty powerful evidence that they did not, they don't actually have all these comorbidities. The skilled nursing system is just tacking these things on to increase coding.
Yeah. Another question from Eileen. Have you looked at whether actual staff numbers are sufficient to provide the care that was billed for?
We have done some work there, but we could probably.
Yeah, we probably could do more there. One issue is that we can see the amount of resident hours per day, unless you're willing to take a kind of strong stance on how many resident hours per day are required to provide these services. It may be difficult to make statements like that.
Yeah. Okay, I have just a couple more questions, and then I have a couple slides to wrap up with. So one of the questions is from Dennis Short. It says some states are aligning their Medicaid payment model to PDPM. Do you anticipate replicating these findings with Medicaid payments?
I guess I would speculate that based on the way that the reimbursement scheme is organized, if it's a similar scheme, you probably will have kind of similar issues with facilities that are selectively using very high reimbursement codes. So the PDPM system is very subject to upcoding concerns. And so if state level agencies are introducing similar reimbursement systems, I would certainly imagine they'll have similar problems.
And Joan Burke says, it seems very easy for these mergers and acquisitions to take place. What is the process that makes this happen, especially in the existing poor performing facilities of the big groups?
So state level agencies are tasked with screening mergers and acquisitions. It seems that if these poorly performing systems are indeed acquiring facilities at much higher rates, that the state level regulators are not using that information, or at least not weighting it heavily in terms of approving and screening these mergers.
Roxanne Montgomery wants to know, how up to date are the ratings on Watch.Care? Is that Watch.Care? Is that correct?
Care.watch.
Care.watch. Okay, thank you.
Yeah, they include data up until the end of 2023. And so though, but you know, those we do use information from prior years because our research shows that practices are very sticky across years. It could always be this case that a bad system was taken over. Bad system was taken over by a good system, and then things improved. In our data, it's more likely that there's a good system that's taken over by a system with bad practices. In which case, our ratings might, if it just happened recently, our ratings wouldn't reflect that. So they do use data up until 2023, but they also include data prior to that. So the ratings are kind of sticky.
Okay, thanks. And the last question I have here is again from Eileen Henshaw. How can we help spread the word about opportunistic facilities?
Well, that's a tough one. I don't know. I think to extent that if it could become more public, that and what the data suggests is there's large differences in some of these systems, and yet you know, some of these systems have good ratings by CMS because they're gaming it. And so to the extent that that can be called out, the systems that are you know, and we find their link, the ones that are committing fraud, the ones that are harming patients through the bad reviews and so forth. So I think part of it is a lack of information. You know, you can have facilities on a one-off basis. You can see something harm, but is that a systematic pattern? And that's the nice thing about taking a large data approach is we can say what the data says, and these are facts. So we do you know, we do stand behind our numbers. They're, you know, for any individual facility, there's going to be some noise, but for a system that has 7 or 8 facilities, if they're labeled as a bad system, you know, according to a variety of metrics, then that's what the data says. It's the truth. So we do, you know, we do hope people will take the data more seriously. We also we also know that people in the industry have the power to put pressure on some of these players. So.
Yeah, definitely. Definitely reach out to your local legislators. That's, you know, a big thing that we always tell people. And going to the media, you know, if you hear about some of these things happening in facilities that you're aware of, going to the media is a huge thing to spread the word. So thank you, John and Alex for joining us today and for sharing your work with us. And thank you for everyone for joining us. I just have a couple. I'm just going to share I have a couple more slides that I want to touch on. So we have our January webinar, and we have some people from New Jersey who will discuss how nursing home advocates can work collaboratively with state Medicaid oversight agencies. That will be on January 21st at 1:00 p.m. And the registration link is there. And Rachel, if you could please put that in the chat, that would be great. So please join us in January. You can head to Nursing Home 411. Materials for today's webinar are available at nursinghome411.org/webinar-overbilling-killing, and I will get a recording of today's webinar up by the end of the week. You can find the staffing levels in your state or community at our staffing page. Again, we have the Q2 2024 data up, so be sure to check that out. You can follow us on Instagram for updates, upcoming webinars, and more. And then our Learning Center, we have fact sheets on key nursing home standards. We're always updating and adding to those fact sheets, so please be sure to check those out. We have our assisted living guides, our family empowerment resources, and our abuse, neglect, and crime reporting center. So please head to Nursing Home 411 for any information that you are looking for. And thank you again so much for joining us today, and happy holidays to all. I hope everyone stays safe and has a really great holiday. So thanks again, John and Alex, and thanks for joining us today.
Thank you very much.
Thanks so much for having us. We appreciate the work you'll do.
Thank you. Okay, bye all.